What are biochemical and clinical relapse?
There's different types of relapse disease, and we can define them a bit better going forward. But generally speaking, you need to have some degree of M protein or biochemical lab results that basically signify that the disease has returned. So that could be an M protein value. Generally, that's more than zero point 0.5 grams per deciliter in the blood. And then you have certain other parameters in the urine, also your serum free light chains that can potentially be elevated, suggesting that that disease has returned. We think about relapse disease mainly in the clinic as two distinct scenarios. So the first scenario is a patient is generally asymptomatic without any clear symptoms that we would attribute to myeloma, such as bone disease, bone pain, any evidence of renal insufficiency, fatigue related to anemia, some things that patients present with in the upfront setting. So in patients that have a slow biochemical progression, what we generally mean by that is that we're starting to see their M protein levels rise in the blood or their serum free light chains rise in the blood, and that is not at this point attributing to any particular symptoms in that patient. So that's how a biochemical relapse is defined. And when we think about strict definitions, we usually have about zero point 0.5 grams per deciliter of an M protein M spike that is present. But generally speaking, we think about a presence or absence of symptoms and the trajectory of the rise in their numbers, basically signaling what we think of their disease in terms of not just symptoms at the moment, but also symptoms that may appear in the coming months or the coming years, as opposed to a clinical relapse, which we generally think about patients that are presenting with symptoms, and those could be any of those symptoms I just described, along with a more rapid rise in their blood protein levels, which may signal that the symptoms may be imminent. We're also now using certain cytogenetic markers at the time of relapse to determine what the likelihood of a patient developing some of these symptoms may be in the near future. And sometimes we are tailoring therapy a bit more to that, and whether they have a clinical relapse or a biochemical relapse, even with high-risk cytogenetics, we may actually treat that patient a bit more aggressively with some of our best drugs that we have available.
So basically, when you're dealing with biochemical relapse, you're saying, and you're trying to communicate on average, the numbers are going the wrong way and usually doubled and usually have an absolute increase. So there's 500 milligrams increase in the monoclonal protein in the blood, 200 milligrams increase in the monoclonal protein in the urine, and 100 milligrams per liter increase in the serum free light chain, or essentially doubling from where they were. 25% increase from their lowest level is usually thought to be a biochemical relapse, and that's there. When you have a clinical relapse, it is tucked together, meaning that whether they had those numbers or not that led to a biochemical relapse, they have worsening myeloma. So you can have a very slight increase in your monoclonal protein, but if you have a new lytic lesion, if you have a new spot on your PET scan, or you become hypercalcemic and it's thought to be related to your plasma cell disorder, that's clinical relapse. So it's a clinical sign or symptom that leads you to begin treatment almost immediately.
What are the differences between biochemical and clinical relapse?
So biochemical progression is different from clinical relapse. So when we say biochemical progression, it means that your M spike or your myeloma has been treated to a point where the number hits something nice and low, preferably 0, let's say. As we notice that your myeloma starts growing back and your M spike starts rising again, we can trend that number and see that the M spike goes from 0 to 0.2 to 0.5 or whatever that may be. The concept of the number rising before it has actually caused any problem in your body, that CRAB criteria we talk about, is true biochemical progression. As opposed to clinical relapse means that the myeloma has started to grow to a point now where it's affected your body in some way. So new plasmacytomas, new bone damage, new anemia, new hypercalcemia, new kidney dysfunction, that is true clinical relapse, and what we're really just trying to hope to avoid as best as we can. Progressive disease based on IMWG response criteria is defined as having an absolute change by 0.5 on your M spike. So the difference is a slow and steady progression without damage being done to your body is biochemical progression versus that slow and steady or rapid and steady to point of progression where it now affects your body in some way.